all the organizers. So Kawasaki disease, I would like to speak from the on behalf of a cardiologist. There is a cardiologist perspective. So clinical features, I'll directly go to the clinical features of the cardiovascular manifestations what we really have. Like as Priyanka has depicted, apart from the other clinical features, I would like to concentrate only on the cardiac part. During the acute phase, the patients may manifest signs of myocarditis, though it is rare. Even the children may present in a shock state, sinus tachycardia, which is out of proportion to the fever, a gallop rhythm, or muffled heart tones, presumably because of some dysfunction or some pericardial effusion. But these are generally self-limited and improve with IVIG treatment, and overt heart failure may occur occasionally. So the levels to distinguish whether the child is having some sort of a myocarditis or it is part and parcel of the disease process, we can do a pro-BNP and a troponin I, though these are not routinely done unless and until we really suspect that the child is having some cardiac dysfunction. And they can be elevated in the acute phase, though the correct clinical significance is not routinely tested in this kind of a patients. A pericardial effusion by echocardiography is also not uncommon. Generally, it signifies some amount of serositis, which is part and parcel of the serositis of the Kawasaki disease, which is a multi-system disorder, as we have told, but generally it's less than 1 millimeter. And tamponade is very rare. Systolic murmurs are audible due to increased cardiac output and anemia, and mitral regurgitation may be seen in 1/4 of patients. This is because of some sort of a valvulitis, and obviously because of the dysfunction, volume overload, we can have mitral regurgitation because of the dilatation. Children occasionally present with low cardiac output shock, and the risk factors for this presentation may be associated with GI symptoms as well, which can be a surrogate marker for risk factors. Coronary arteries, these are of prime importance as a cardiologist because these are the main owners of a Kawasaki disease, whereby we can have coronary artery changes in all shorts and frames in a case of Kawasaki disease. Coronary artery dilatation or enhanced perivascular brightness may be seen in 30 to 50% of patients, which is one of the mainstays and the diagnosis of the Kawasaki disease. Though in the recent classification, this has almost been given up because this is very, very individualistic. Whatever may be the enhanced perivascular brightness to me may not be so to any other signal. So we try to give less than importance to this one nowadays. During the activities of the case, this can be seen up to 30 to 50% of patients. Without IVIG treatment, the coronary arteries may become aneurysmal within a period of 1 to 3 weeks from the onset of illness, with an average, say, of 7 to 10 days. That is the reason if the echocardiogram is done within the first week, a number of times we can get a normal echocardiogram only to find an aneurysm in the 3rd week or even later. Sorry. Reported rates of aneurysm vary based on the definition of an aneurysm used, which are different according to different criteria. The Japanese National Kawasaki Disease Surveillance data produces incidence of CA dilatation is about 7.26%, aneurysms about 1.04%, and giant aneurysms is less and is approximately 0.24%. The Pediatric Health Information System, an administrative database of freestanding children's hospitals, which rates the aneurysms between to 5.9%. Now, the coronary aneurysms, most frequently they are seen in the proximal segments of the LAD and the RCA, and the less commonly seen in the LMCA. The circumflex is the least often involved. Again, an aneurysm in the distal artery segment is usually, but not always, accompanied by an aneurysm in the proximal segment of the same artery. What is the applied importance? The applied importance is, for example, to diagnose any case of Kawasaki's disease, we always look forward to any aneurysms, which are obviously the echocardiographic limitations are that we can see only the proximal segments of the coronary arteries. When the coronary arteries take the bend and twine around the heart, it is very difficult to find out if there are any coronary artery aneurysms in the distal part. Likewise, if you stand on the banks of a river, we can see the proximal segment of the river as long as the river is not taking a bend beyond the horizon. But obviously, we cannot see the part of the river which is beyond the horizon when the river takes the bend. This is the segment which we normally use to make the things explainable to the parents. And aneurysms with internal diameters of more than 8 millimeters or a Z-score of more than 10, there is a giant aneurysms, are disproportionately carry a higher risk of myocardial infarction. So the risk scores for the development of coronary artery aneurysms, are there any risk factors, whether we can predict something? Yes, based on the clinical and laboratory data at presentation, there are independent factors are that protracted fever, presumably reflecting worse vasculitis, anemia, elevated WBCs, low albumin, elevated CRPs, male gender, age less than 1 year, more than 9 years, and the largest baseline coronary artery diameters if possible. Rarely, KD patients experience myocardial infarctions as well. The myocardial infarctions present differently in childhood compared to adults, with the most common symptoms being shock, chest pain, vomiting, inconsolable crying, and abdominal pain. And these factors are very often, they're very, very difficult for the parents to pay heed to. And they, in any part, and the child, a crying child, may have different reasons. Especially, it has been reported that referred left otalgia can even be a manifestation of myocardial infarction. Chest pain is reported much less frequently in children younger than 4 years of age, and about 1/3 are asymptomatic at the time of infarction, and which may happen at rest or during sleep, and infrequently during exertion. And the first episode fatality of myocardial infarction has been reported as high as 22%, with progressively worsening mortality rates. Now, the giant aneurysms are received with the higher rates of mortality, rarely rupture causing sudden death, though the reports are very, very less. In general, late consequences of KD are isolated to cardiovascular disease and occur only in patients who had coronary disease at presentation. Overall survival rates at 10, 20, and 30 years after the onset of KD have been reported as 95, 88, and 88 respectively. Now, the electrocardiographic features during the acute phase of the KD, the ECG may show sinus tachycardia, prolongation of PR and corrected QT intervals, decreased QRS voltage and TUF flattening, presence of large aneurysms leading to acute myocardial infarction. Manifest at ST elevation in burst waves. Thrombosis of an RC aneurysm may produce a silent posterior wall infarction, abnormally deep Q waves in 2, 3, and ABI. This is an example where this is one of our patients who had a myocardial infarction at the age of 3 years, and as you can see, it was an anti-wall infarction. There are Q waves here, which never did quite recover. Now, the radiological features, chest radical is usually unremarkable. The echo features to look for: findings of perivascular brightness, mild coronary artery ectasia, lack of tapering, and relatively common in the acute stage. With decreased LV contractility, diastolic dysfunction, valvular regurgitation is mostly in the form of mitral regurgitation. Later on, aortic regurgitation may occur in the chronic phase. This is an example where one of our patients actually presented with dysfunction. You can see the left ventricle is dilated and the patient has presented with dysfunction. In one of the other cases, this is an example of the perivascular cuffing where the wall of the coronary artery seems to be thickened and more bright compared to the adjacent ones. This is a case of a Kawasaki disease. It is actually on the convention, we should not measure at the very beginning of the coronary artery, and preferably we should zoom the echo to minimize the chance of errors. This is a perivascular cuffing and the dilated coronary arteries. This is the LAD and the circumflex, and in here you can find there was some amount of dysfunction in the later half. There is a patient who presented with dysfunction and the dilated LAD with some amount of mitral regurgitation, as you can see. The next one, this is one of our prize patients. You can see the right coronary artery is dilated, is about 4 millimeters, and the left coronary artery actually houses a giant aneurysm with completely occluding thrombus measuring 13 into 16 millimeters. This is the thrombus which had actually occluded the left main coronary artery. This patient presented about 2 years after he had Kawasaki's disease with the clinical diagnosis of dilated cardiomyopathy. And when we were trying to find out what was the reason of the dilated cardiomyopathy, we found out that this child, we took the history from the mother, he had symptoms like Kawasaki's disease, resembling Kawasaki's disease, and had a giant aneurysm which was completely occluded with the thrombus, and hence he had presented with the post-myocardial infarction dilated cardiomyopathy at the age of 3 years. This is a pediatric multisystem inflammatory syndrome which recently came to our hospital. As you can see here, there are dilated coronary arteries which are more than 2.5 z-scores for the child, 3.39 millimeters, and on the right side, this was the findings. And surprisingly, these findings came down within a span of 1 month when we examined the child later, 1 month later. So echocardiogram is usually done 2 to 6 weeks after the onset of the illness to understand the extent of the coronary involvement and guide the therapy. New abnormalities are unlikely to be detected at 6 weeks if the initial echocardiogram was uneventful, with normal coronary arteries at baseline and at 2 weeks. So at 6 weeks, usually we do not expect unless there is some catastrophe. But echo is done more frequently in more complicated clinical courses. For example, in large aneurysms or even giant aneurysms, we do twice weekly early in the disease, or then weekly and monthly and every 3 months for the first year, further to understand whether it is getting thrombosed or not. The global left ventricular function, regional wall motions, competency of the mitral and aortic valves, proximal segments, distal segments are usually difficult to visualize. Now, Japanese Kawasaki Disease Research Committee, what are the standards by which we measure? By these standards, by the Japanese standards, if the internal diameter is more than 3 millimeters in children less than 5 years and more than 4 millimeters in children more than 5 years, more than equal to 5 years of age, or the internal diameter of a segment is more than 1.5 times that of an adjacent segment, or a coronary artery is clearly irregular, then we can find it and classify it as abnormal. Nakano et al. In his paper showed that angiographically measured coronary artery diameters correlated with the BSA. Now comes the role of the Z-scores, which are actually calculated on the statistical methods. If the BSA is less than 0.5 meters squares, coronary arteries measured usually less than equal to 2.5 millimeters. From 0.5 to 1 meter squares, coronary arteries measured 2.5 to 3. If the BSA was more than 1 meter square, they measured more than equal to 3 millimeters. They published the normative coronary artery dimensions by echocardiography with wide range of values, and in 2010, et al. They showed that the BSA characteristics are more acceptable and they give more closer results. Drizodi et al. Adjusted the BSA adjusted internal diameters were published, and 27% showed that 27% of the normal coronary arteries by the Japanese criteria were actually abnormal and enlarged at least by one coronary artery when the Z-score was more than 2.5. So the alternate aneurysm classification schema were found out, and the Z-score by the Z-score method, a small aneurysm becomes a more than equal to 2.5 to 5 Z-scores, large aneurysms more than 5 to less than 10, and the giant aneurysm has a Z-score of more than equal to 10. So you can see that the evolution of the coronary artery measurements according to the need of the day and the need of the hour. Now, from a cardiologist perspective, in the acute stage, when were we called for? We were called when there is a management of the coronary thrombosis. Apart from the diagnostic part being over, then comes the management part. Obviously, Priyankar and Shupanandi will be telling you about the management part. Of the specialist cardiological part, I'd like to give you one example. This baby came to us from another hospital, age of 5 weeks, and we found that the child was having Kawasaki disease with aneurysms, and there was a clot in the LED. To our horror, there was a clot in the LED. Now, the protocol says that the correct method to get over the clot is to go for cardiac catheterization and streptokinase or multiplex therapy. But this baby was only 5 weeks, and we didn't have enough of the hardware. And it has been mentioned in the protocol that if we cannot go inside, then we can just go for multiplex therapy. That's what we did. We went for recombinant tissue plasminogen activator therapy, and we found out that gradually the clots became smaller and the child was discharged on low molecular heparin and aspirin. The cardiac cath is not immediately possible if the patient is too small. We can start multiplex or RTP at 0.5 milligram per kilo per hour intravenously for 6 hours with low dose aspirin, therapeutic heparin infusion to achieve a PTT of 50 to 70 seconds. Third case, when the cardiologist called for. Though this is basically an intensivist area, but management of a cardiogenic shock. Rarely, Kawasaki disease patients can present with cardiogenic shock with the need for intubation and ventilation, regular inotropic supports, diuretics to reduce the preload and afterload reducing agents like milrinone, GTN, and levosimendan. Cardiac catheterization and angiography, the role of cardiac catheterization and angiography doesn't come in the acute one. So gradually we are going into the phase where the patient has been diagnosed, acutely managed, and on the follow-up of a cardiologist and a pediatrician. So cardiac catheterization and angiography are done to for the prognostication and the therapeutic purposes. Whenever there is an echo evidence of large or multiple coronary aneurysms, or with clinical ECG or stress test evidence of myocardial ischemia, we usually go for a cardiac catheterization by the protocol at approximately between 1 to 2 years. But elective catheterizations are not recommended in the acute phase, mainly because lack of additional information gain. We gain most of the information by echocardiography, and there is a higher risk of arterial complications seen in acute AD. So emergency cath may be necessary for therapeutic decision-making cases where coronary thrombosis is suspected, as the example which I showed. LV-EDP may be measured, but obviously the LV-EDP can be measured indirectly by echocardiography, so it is not much of a use. If cath is necessary at all, the safety and efficacy has to be established, Selective coronary arteriography is advantageous over an aortic root injection because it gives visualization of the aneurysms, obstructions, and collateral arteries. Planning the treatment and post-treatment evaluation for CABG and thrombolytic therapy, and interventional catheterizations can be used for revascularization patients. There has been papers where there has been acute stenosis, especially in the areas immediately following the dilated part, where there can be an acute stenosis leading to myocardial infarction. So this is an example of the patient whom I showed, who was having a completely occluded left main thrombus. Here you can see that the left main coronary artery has been blocked and the right coronary artery through the collaterals and the retrograde perfusion is maintaining the myocardial perfusion. And this is the second shot where you can see this in another angle. So the left main coronary artery is totally blocked. This particular child had a CABG done, there is coronary bypass grafting done from the left internal mammary artery to the left system at the age of 8 years. This is another example of, this child came to our hospital. There's an aneurysm in the LAD and there's another aneurysm here just beside the left main coronary artery. There's another aneurysm in the right coronary artery as depicted in this picture in the distal part of the right coronary artery. So this particular patient was on medical management because he was not that symptomatic. The role of a CT angiogram or cardiac catheterization is 1 year after as per the guidelines. Because CT angiogram comes in a role whenever the cardiac catheterization is not contemplated or is difficult or the child is small or there are other involvement. Particularly peripheral artery aneurysms are involved, even axillary artery or the iliac arteries may be involved. The CT, but one word of caution, the CT angiogram can only be done in a child if the speed of the CT is especially beyond 126. Otherwise, what happens, the child's heart rate usually ranges between 120 to 140, especially when the child is agitated and the child is fearful. So that either the child has been sedated or with the use of beta blockers where to bring down the heart rate so that the child's coronary arteries can be mapped onto. But to be very frank, to get a very good coronary artery CT angiogram, we have to have a 256 live CT. Radionuclide scan, this is an example of the child which we were talking about with left main coronary thrombosis. We found that there was viable myocardium still, and hence we went ahead with the CABG and the child is now doing well. Later on, he was having incessant ventricular tachycardia, hence he underwent a AICD implantation later on. So the treatment in the chronic phase, now the child is grown up and post Kawasaki's disease, maybe 7 or 8 years down the lane, coronary risk stratification is done regarding the long-term management. We follow the AHA guidelines regarding interim guidelines regarding the management of antiplatelet or anticoagulant therapies, restriction of physical activities, frequency of cardiac evaluation, and the types of diagnostic tests and the regular activities. Because the parents often come to us, what kind of lifestyle can the child lead? Whether he can take part in sports, especially active sports and body contact sports. The patient's overall risk may decrease or increase over time depending on whether the coronary artery aneurysm or aneurysms undergo regression or develop an obstructive lesion. Usually it is seen, even if there are aneurysms, most of them come down with a z-score of say 4 to 5. They usually come down within a span of 1 to 2 years. But they can lead to other problems. Now there comes the question of anticoagulation for giant aneurysms. Usually our pediatrician colleagues take care of this one. Sometimes the patient come to us. Giant aneurysms, particularly susceptible to thrombotic occlusions, the overall probability of either complete thrombotic occlusions or severe stenosis requiring surgery or even death caused by myocardial infarction, which is approximately estimated to be 7.5% per year for kidney patients with giant aneurysms. And they may be treated when they are treated aspirin therapy alone. Hence, warfarin is introduced, which likely improves event-free survival, but experiences high rates of adverse events such as bleeding, recurring transfusion, or hematoma evacuation, and despite intensive monitoring by a dedicated pediatric anticoagulation team. And patients with giant aneurysms, the warfarin usually it is treated as if equivalent to a mitral valve replacement therapy, mechanical prosthetic mitral valve, and the INR is kept around 2.5 to 3.5. Children with a history of coronary thrombosis sometimes manage a triple therapy, warfarin, aspirin, and clopidogrel. So the coronary risk stratification by the AHA, if there is no coronary artery changes at any stage of illness or even a transient coronary artery ectasia, I marked it as green, where the pharmacologic therapy is not needed beyond the first 6 to 8 weeks. They can have no restriction, they do not have any restrictions in physical activity, and on the long run, long-term recommendations are done. They can undergo, no invasive tests are recommended on the long run. and cardiovascular disease assessment, the counseling can be done at 3 to 5 year intervals. But if they have one small medium coronary artery aneurysm or a major coronary artery, they have to be on low dose aspirin until the aneurysm regression is documented and physical activity is gradually slightly restricted. Follow-up diagnostic testing, they have to have an annual cardiology examination with echo, ECG, X-ray, and regular counseling with biennial stress test and evaluation of microperfusion scan. If there are more than one large or giant coronary artery aneurysms, they have to be on warfarin with the target INR of 2.5 with additional heparin and or aspirin, biannual checkup with echo, ECG, and annual stress evaluation with myocardial perfusion scan, and an angiogram approximately 6 to 12 months. And if there is a coronary artery obstruction, which is very rare though, they have to be on long-term low-dose aspirin, warfarin, or LMWH, and contact or high infantile impulse force should be avoided. Biannual follow-up with angiography recommended to address the therapeutic options. So these were in summary, the cardiologist aspect. On the very long run, for example, when this same person grows up and carries a married life, and they enter the second phase of life, as Priyanka was telling, on the long run, these people have been noted to have more of an atherosclerotic flux. So the recent recommendations say that they have to be on atorvastatin or lipid-lowering agents as well, so that the plaque formation and the thrombus formation are decreased. Thank you very much.
Thank you, Dr. Amitabha. Warm good evening to the other doctors who are